Okay, well, my name is Steve Oil, and I just want to share, first of all, that doing a Zoom training from home is very fun because I didn't spend a lot of time on my tie. It didn't matter what length it was because you're only going to see about this much of it. So I was very happy about that this morning. Um, Helen, when you're ready, let's do the next slide. And all right, Jen, I'll introduce myself and then I'll go to you. Okay. So as I said, my name's Steve Oil. I am a credentialed family peer advocate, which means I help parents of youth with disabilities. I help them walk and navigate their paths and the many systems their kids will need for support. And I provide emotional support and advocacy for them through my job and outside of my job as well. I've been at Northern Rivers for over 16 years now in the same role, and I've been in human services over about 35 years, a little bit more. I always say that, when I started, I had a great head of hair. I think I had a great head of hair. Maybe not everyone agrees with that. So it was a long time ago. But I've worked with kids and families throughout that in shelters, in residential settings. I've done care management in the shelter. I've done transportation, overnights, and the last 16 years focused on providing the family support piece for parents. I have a 26-year-old son, my wife and I, who is on the autism spectrum, and that's what got me shifted into this part of human services about 20 years ago, more than 20, probably about 22, 23 years ago. So, and of all the work I've done in human services, this is my most favorite work that I've done, which is probably why I've done the same job for the last 16 years and the one I'm most passionate about. So I'm proud to be here today, and I hope I can impart some knowledge to help all of you out there, whether you have families or students or friends that you need to help. So with that, I'd like to pass this over to Jen.
All right. Thank you, Steve, and thank you, Helen, for the introductions. Good morning, everybody. My name is Jennifer Hayden. I am an LMHC, or licensed mental health counselor, and a certified alcohol and substance use counselor. I currently work at the Schenectady County Office of Community Services. And I do want to throw one quick thing out there today before I say anything else about myself. Unfortunately, I'm a little under the weather today. I'm still very happy to be here. I'm feeling good enough to do a presentation and looking forward to dialoguing with everybody later, hopefully, when we have some questions and answers. But did just want to say, appreciate folks meeting me where I'm at today. And if I do have to turn my screen off, hopefully I won't have any coughing fits or anything unpleasant like that. We can just go smoothly through this together. But if I do have to pop off, that's probably why. And we'll just do the best we can. So I'm very happy to be here with the Special Education Task Force today and behavioral health colleagues who have joined us. This is my first introduction to the task force. I know you all do a lot of great work. So excited to talk with you all today. I'm going to be primarily bringing the perspective of substance use in the community and mental health. And so my background is with working with our local stakeholders that are in the behavioral health realm, who work with folks with a substance use disorder or mental health challenges. And we also work with folks who might have developmental disability as well. Although my primary scope is working with the adult population, I certainly do tackle youth-related topics, and I'm happy to be here today to talk a little bit more about that and unpack that further. That being said, if there's questions or comments you have that I don't have an immediate answer for, I would be happy to go back to my team, especially if it's pertaining to youth, answer those questions and then get back to folks. So I have been so my current role is dual recovery coordinator, dual meaning substance use and mental health coordinator. I work in 797 Broadway building in Schenectady on the third floor, but we're always trying to be out and about in the community and meeting folks and agencies where they're at. I have about 15 years in the human services field. So I've worked as a clinician, a direct caregiver, and now my role is a little bit more macro. So I have some perspectives on like larger systems, trends, and changes that I'm going to bring to the table today. So Steve, I'll kick it back to you for a minute. Good to see everyone.
Great, thanks, Jen. So May is Mental Health Month. So when we were developing this training, we wanted to do something with mental health. And with COVID and the shutdown, and that we're out of the shutdown. Obviously, that was a couple of years and different levels. I don't think we'll ever get rid of COVID, because I want to share, I read something on Johns Hopkins during the shutdown that the flu strains that we have now are still strains from the Spanish flu of 1917, I think it was. So I think that COVID's not going anywhere, and it'll keep changing, similar to the flu. And for those that believe in it, like myself, I think vaccines will help, and I think the strains get weaker, but I think we'll be keeping our eye open on that. Meanwhile, things have changed in the last 3, 4, or 5 years, and a lot due to COVID. So we thought we'd talk about mental health, kind of post-COVID, if you will. I don't really like that phrase, but and then to do that, we also felt like you have to have some kind of parameter of. I mean, there's a lot when you say mental health or mental illness. There's a lot to consider, and with COVID, it's worldwide. So we started out by saying, well, it's not only affected people's mental health, and we're going to talk about that in a minute, but it's also affected substance abuse. It's affected people with developmental disabilities and families, and it's just been a very rough time. So let's start out with the idea of what's happening all over. Okay, so I want to go through a couple of these points. The World Health Organization is saying that the COVID-19 pandemic has triggered 25% increase in how much anxiety and depression there is in the world. Okay. The reasons is because of unprecedented stress, social isolation, constraints on the ability to actually do work, and also to seek support from loved ones and to engage in their communities. I'd like to jump into it really quick, the last part, seeking support from loved ones and engage in their communities. I think we all, if you watch the news the last few years, the nursing homes and residential settings for people with developmental disabilities were really highlighted in the news. And there was a lot of suffering where people would go see their grandparents or their parents who were sick and elderly, and they couldn't go in the building, visiting from windows during the winter outside, sometimes the windows just being closed. So that leads to more stress. It's not your standard thing. I like to add a little anomaly in the idea of working from home. A lot of extroverts, if you watch social media, especially the first year of the pandemic, first few months really, and the shutdown, a lot of extroverts were really wanting to go back to the office and saying, when we get back, I'm going to hug everybody. I'm going to, I can't wait to see everyone and talk to everyone. And the anomaly is me, because I'm a huge extrovert, and I might be the only extrovert that loved and still does. That's my kitchen behind me. Still loves working from home, in part because organization doesn't come naturally to me. I have to work very hard to be organized. And I get much fewer interruptions, and I get much more work done. So the other part, the non-extrovert part of me, is like, this is great. I've noticed that people don't call me unless they really need to ask me a question, or else they'll just email me. If I'm in the office, people will come see me because I'm in the office. I'll just go over and see Steve. And by the way, I am part of that problem when I'm in the office too. When I can't concentrate, I'll say, let me just go see what Jen's doing. I'll ask her this question, but and I might spend 15 minutes there. So I get that I'm part of the problem, which is why I liked being shut in at home in terms of getting work done. So anyhow, but back to stressors, there's so much of this that was a huge change for people, regardless of their personality. So anxiety and depression have definitely increased. Reasons that led to those things were loneliness, people being afraid of being infected, suffering, death for loved ones, like people that are sick, people that died in the hospital alone, and then grief after bereaving people, and then financial worries. A lot of people lost work, they couldn't work, or they weren't able to do things to make any money. So this is, it affected all these major facets of our lives. And I think, and certainly when it comes to changes in our work and our daily lives, exhaustion kind of sets in just naturally. And certainly there's been a lot of sharing and information in the field of human services that health workers, starting with, people in the hospitals, nurses, doctors, anyone that's working in hospital settings during the shutdown, how much harder that was and how much more stressful it was, seeing patients not having friends and family being able to visit, and just doing the regular work that is so tiring. And anyway, for medical folks, that exhaustion was a major trigger for suicidal thinking. So I just think those are huge, huge points. We want to just kind of say that's where we started with the pandemic, and we're still seeing a lot of that. Maybe not the same numbers or same intensity, but we are still seeing regular effects from these things. Okay, Helen, next slide, please. So in developmental disabilities, the Association of American Medical Colleges, now, from their website in 2021, April, a year ago, well, a little more than, 2 years ago. Oh my gosh, 2 years ago. About 6.5 million people in the US have intellectual disabilities, which means they have an IQ score below 70, typically, and they have other cognitive limitations. So their communication, their social skills, their self-care skills, that's the amount of people that we have in a country like that. And I want to point out, it's easy to kind of have the paradigm of somebody with an intellectual disability. If you think about someone who, I don't really know what the IQ is for people that have Down syndrome, but everyone's familiar with Down syndrome, at least an idea of what that looks like. I think a lot of us in the field, but maybe not everybody in the community, hopefully they do, but not everyone knows that there's so many levels of different skill sets within intellectual disabilities. And if you include some people with autism in this definition that have IQs under 70, they still have many of them still have, what's the right word here? They have they have some, we call it splinter skills. So some of their skills are limited and some are very, very good. So not everyone fits the image we have of what an intellectual disability in a person looks like. So we have to be cautious about that we don't just lump this group of people off as they're very limited. Some are, and they still are people inside, and they still enjoy facets of life, whether we always recognize that or not. And I just think that's an important distinction, because in our field, we have people that have very high IQs that are on the autism spectrum and also have mental health diagnoses as well, including anxiety and depression and whatnot. So these are all pretty important things to note. And with this, what the AMMC said was that patients with intellectual disabilities were 6 times more likely to die from COVID than other people. And I don't, when I was looking for data and statistics, there was a lot at the beginning of the shutdown regarding COVID and these topics we're talking about today. There is very little that I could find in the last year to 2 years. It was more the very beginning of the shutdown because so much was being tracked. So I was disappointed that we don't have that I couldn't find, and at least a lot of data about this. But I think I just want to share a subjective story or two that I read about online as well, about one person with an intellectual disability, was not, I don't think was very verbal. Their verbal skills in expressing themselves were not a strength, let's say. They could speak some, but it was a challenge for them to communicate that way. And then they got sick. This one woman, 21 years old, was doing good on her job, had a job coach, was being able to work in a it was like a restaurant or a cafe setting, I believe. And but when the shutdown happened, lost their job because they had to shut the place down, and then ended up getting sick eventually with COVID, and then had to be in the hospital. Didn't understand why her family could not come see her, which created more stress. And it was, so you could explain, but it didn't make sense to her why that couldn't happen. And I think stories like that, we just need to hear. Like, we're kind of used to what we either do or what we have around in our own lives. So I just think those are important things. And then the other part to be very concerned about, I don't have a statistic here, but if a patient can't communicate what their symptoms are or what they're feeling, it is harder to treat them. I read one, I'm going to be very cautious here. I read about one institution during the first year of the shutdown that medical staff, let's say, in a medical setting, were kind of making decisions without consent from people with intellectual disabilities about what kind of treatment they would get or if they should be treated at all. So that's very subjective. I don't have good data to share with you on that, but I think that is enough to share that is extremely concerning. It might be extremely difficult to figure out how to help people like that in that scenario, but we have to do better and try harder to make sure that we are figuring that out. Just because it's not easy doesn't mean it's not the right thing. I found out also when I read that same institution, someone kind of got on them and they changed they stopped that practice that they were doing for about a month with a few patients. So that's good to hear. So there's just a lot to consider here. Okay, thanks, Helen. Let's go to the next slide. Some of the increased illness and death. Well, I'm sorry, that first bullet I just kind of was talking about the nature of the intellectual disabilities and the supports they entail. I want to point out another thing real quick about a lot of people with autism. They might do very well with speech and language in a kind of a structured setting. In other words, they might be really good at writing papers. They might be really good about talking about subjects they're aware of. A lot of times, someone with a high IQ with autism, if you ask them their opinion on something, or like, how are you feeling? Like, that is a very difficult concept for many people on the autism spectrum. So that would also fit under intellectual disabilities. And if they don't have, if they're in the hospital and being treated and they don't have family nearby to help communicate or help figure out how to help them communicate, that could lead to trouble as well. Because how do you treat somebody like that? Do you overtreat them or undertreat them as a result? Another reason they talked about the idea that the AAMCC, that they would people with intellectual disabilities had a higher rate of death from COVID is because of a lot of shared experiences, including living in a group home, using shared transportation. So when they went to appointments, when that was allowed, they're in the same van or going together. They're exposed to people outside of their households. So in other words, when we were shutting down, if you lived and you had your family with you and you were working from home, your risk was low because we weren't going shopping often, or we weren't going when it was busy. We weren't exposed to other people. Whereas now in group homes, you have, thank God we had people that were working and coming into the group home, but you still had that variable of people from outside the household coming in. Instead of two parents or two adults or one adult, you had whatever, 5, 10 coming in over a week's period or more. So, and that would include therapists as well and whatnot. Also, I think a lot of us struggle with mask wearing, how to do it properly. Do you ever remember seeing, and maybe you still do, seeing people have a nice big mask on, but their nose is showing? I mean, I don't want to make too much light of that, but it's a little humorous because you're like, well, you got to cover everything. But on a level for intellectual disabilities, it's even more difficult for not just maybe understanding, but also sensory issues that these folks might have, and just really tough to kind of readjusting and whatnot. Next slide, please, Helen. So in mental health, what's been going on? They said, the World Health Organization said it's one of the biggest global crises in generations. It's had severe, far-reaching repercussions for health systems, economies, and societies. I want to mention today that I think I'm a pretty good educational advocate. You know, if the school district is not doing what I think they should be doing, I work hard at trying to point that out and make sure we kind of get something that a kid needs on his IEP, let's say, or a 504 plan. However, during this crisis, and it's still happening now with the workforce crisis that we have, I am very judicious about how hard I push a district. So for example, if they agree a student needs a one-to-one aid, and they say, well, but we're trying to hire someone, we can't hire someone. I think before the pandemic, I'd have busted their chops a little bit more, like, well, figure out something. But it's really hard to get blood from a stone. And right now, every business that I'm aware of is just having trouble hiring people. So I share that in that sense that the pandemic is affecting, certainly in our country as well, everybody, including the education system, who already has such a hard job, and really came to the challenge during the shutdown, which was very difficult for kids and for the teachers and the staff. And they made it through, not unscathed, I think, but they made it through. So there's just so much happening, and it all affects our mental health. People have died, people have lost their jobs, they're not back at their jobs, some of them. Communities, families, they're separated, they've been stressed, and coming back, they're not coming back. It's not like just returning home after a couple of years. They are changed people because of their mental health related symptoms and or diagnoses, or not recognized diagnoses if they haven't gotten any help yet. Socialization has suffered, and you know, even the most introverted people I know, when they have a social interaction with someone that they enjoy and they plan on, that really means something to them. So I think we all, the extroverts and the introverts, are suffering from the lack of socialization that has happened during the shutdown and the pandemic. Many people in businesses have gone bankrupt. Many people are below the poverty line that were not below before the shutdown and before the pandemic. So it's affecting everyone. You know, you don't go home and all the stuff we just talked about on this slide and say, well, tomorrow's another day. That is very hard to just say, hey, here we go. I'm going to pick up tomorrow and feel better. That's not how it works, especially when you're talking about clinical diagnoses, clinical depression, clinical anxiety. So thank you. Okay, Helen, let's do another one. Another slide. So I might have covered all this, but let me see. Yeah, you know, I think that as much in the field with mental health, and I would say substance use and misuse, that as much as we do, I think we're constantly working on talking about suicide and suicide ideation and not making it a taboo subject. I think it's a difficult one for all of us because if it's completed, it's very final, and that really upsets people and makes people very, very sad. But that being said, I think we'd be naive to not recognize, whether you're hearing about it or not, that there's been increased and more widespread suicidal thoughts and behaviors from people, and certainly from our youths. I wish I had good stats on that, but I don't think they exist in the last year or two. But I think subjectively I can share that I have seen in the last 6 months in my job working with youth that have mental health and mental illness issues, their needs and their parents' needs psychiatrically have increased tremendously. I can see it in them, and I can see how it affects the work that I'm trying to do. And then you have the other providers are feeling the same way for themselves, trying not to bring it to work. So I think we have to recognize that more people are having suicidal thoughts and ideas, and some are having behaviors, and including among healthcare workers, especially I think in the hospitals. A couple of years back and still happening now. So we just have to just recognize that. Okay, Helen, thank you. Next slide. And by the way, I'm hoping that if people have questions or comments, you're putting them in the chat. Helen will do a great job. She always does of, if it feels like something she should share right during the training, she will. And if not, we'll get to it at the end with questions and answers. But if you don't wait for the end, just put your comments or questions in the chat.
We've got no
Yes.
questions in the chat right now.
Okay, do you want to do those now?
Or no, I said we have none.
Oh, none. Okay. Sorry. I didn't have my
No.
good hearing going.
No worries.
Okay. Thanks, Helen.
Yep.
Let's see here. So, some people have been affected more than others. You know, one we haven't talked about yet today is university closures and university, virtual learning through universities in the first year for sure. An extended school for folks. Again, it just makes people vulnerable to social isolation and disconnectedness. I think that a lot of us learn to use virtual Zoom and Google Meet for social, and I think that helped, but it's not enough. I mean, I made light before when I was talking about extroverts, like, I can't wait to hug everybody. I shouldn't make light of that. I didn't mean to put it quite that. I didn't mean to make that much light of it. I just meant that from my own experience in terms of work, I was like, don't worry, I'm good. I'll hug you in 5 years after my work's all done. But I do think that, when people don't get what they need, if they need that more regularly than I needed it through work, or you need it personally, and you're not getting that, that definitely gets people sad, anxious. Most of us, whether we're organized or not, we like a plan. We like to know what's coming up, even if it's only moments ahead. Ooh, you want to go out? Okay, where are we going to go? And then you start getting excited. None of that was happening. And that can definitely lead to behavioral problems for kids and adults, being lonely and just being very down. Okay, yeah, another thing, being at home with your family, for some families, increase the risk for abuse, like physical abuse, so there's the old story about the father coming home from work and being angry and can't manage his anger and kicking the cat. So I think, it would be naive to not think that parents' frustration about having the kids home all day, about not being able to go to work, and not being able to go out, do anything, on a regular basis, led to more frustration, more anxiety, more anger, and sometimes that anger may have gone physical. So that's a big problem. It says, one of the reports said that 45% of women had experienced some form of violence, either directly or indirectly, during the first year of the pandemic. So again, in terms of domestic violence, remember, domestic violence is not only physical violence. It is also mental and emotional violence. So controlling your partner. So men, in this example, I'll say men controlling women, whether it's through money or just intimidation, even if there's no physical interaction of hitting or hurting. I couldn't speak to it clinically, but it seems to me it's almost the same thing. I don't try to judge that the physical is worse than the emotional control. I think they're the same at least, or maybe the emotional is even worse. So all this have increased. So people's mental health, again, continues to be challenged and more difficult. Okay, Helen, let's do another one. So it went back. Can we go to the next one, Helen? Oh, was that me? There we go. Thank you. Yeah, and mental health services have been disrupted also. You know, one of the pluses though was virtual and telehealth, especially for counseling and therapy, because some kids and some adults actually did better with this. Some I know some kids, the parents tell me like, no, they need to be face to face. Like we tried virtual, it just did not work. But for some kids, it's a great starting point because they're a little they might not be ready for the therapy they need. So it's a little less intimidating, a little less intense to be on a call like this, a virtual call. With another thing that happened was appointments, people getting to their clinical appointments, both adults and kids. The rate of getting there increased tremendously. So more people were making their appointments. And I think I can speak for families, you know, whether they're urban or rural or suburban, but that was increased because if you have 3 kids and you're a single parent and you get home from work and one kid has therapy, all 4 of you are going to therapy. You can't leave the other kids home unless they're much older. So that means you're bringing the whole family out. Usually it's after work. You got if you don't have a car, you're relying on the bus system or the Medicab, and that can take longer than just taking your car back and forth. Then you still got to feed the kids. Whereas during the pandemic, when the virtual worked well for the youth, parent comes home, puts the child on their virtual session in the bedroom, and then goes and makes dinner. By the time the client's done, the kid's done, it's dinner time. Nobody else had to be disrupted. So there were benefits to the telehealth stuff, but the way we did business definitely was disrupted, and it didn't work for everybody. Also, I think we have to keep in mind that poor knowledge and misinformation about what COVID was and how it spread in the beginning, especially, would fuel fears and worries from people. And if I found that some parents would, you know, go to social media for their information, and at best, that is extremely subjective in my view. So it depends on whose social media you're reading, and it might not be validated information or whatnot. So that was concerning for me as a provider about how people made decisions about what they're going to do. If you recall, in the beginning, we were all about hand washing. Well, I mean, there was many things: wearing a mask, keeping your distance, not going out in crowds when you needed to do like shopping, but also washing our hands like crazy. Now that's a great practice, but I think this is just my subjective view. I have not studied this. I think that the hand washing has decreased because we've found that the COVID virus is spread airborne. And, you know, so if I'm right on that, I would say it's safer to shake someone's hand than to give them a hug without both of you wearing masks in terms of the spread of the disease. So I think information like that changed legitimately. And again, who's getting that information? And again, like, well, do you just stop washing your hands? No, that's a good practice in general, even before COVID was out. So all these things, all these changes, and all these trying to keep up makes it very difficult in people's mental health. Okay, Helen, what do you got there? The next slide, I mean, sorry. What do you got there? All right, Jen, I think, by the way, let me just say, it's really important that we kind of set the stage of what's been happening. So I apologize if that was kind of a downer, but it's really important to acknowledge it all. So with that, I'm going to toss it over to Jen to go into the next slide and continue our presentation.
Okay, thank you, Steve. Thank you. Hi, everybody. So before I jump into addictions, actually, as Steve was talking, and kind of thank you, Steve, for describing the landscape. I do think it's helpful for us to be reminded of where we've come from and where we are now. And it kind of sets the scene, right? It sets the stage for this continued conversation that we're having, because it's certainly, there's a lot of significant changes that have happened that are contributing to what's going on now. So I certainly appreciate that. Makes my job a little bit easier. But before we dive into the addictions, I did just want to say one quick thing about the the changes that COVID has had for parents and for little kids. On a personal note, I am a parent myself. I have a 3.5-year-old, and Lucas was about half a year old when we entered the pandemic. And, it's funny because I don't know if there's I'm sure there's other parents in the crowd today, or family members who have had to see firsthand the impact on some delays for children related to speech or development learning that might not have been the case if COVID was not present. So for my own personal experience, our son had a bit of a language delay and had to receive early intervention services. And I share that freely for several reasons. First of all, to kind of decrease the stigma, because I think there's no problem in getting early intervention services. And I think if we share our own stories, it kind of breaks the stigma. We had an amazing experience with Schenectady County early intervention services. But also when we were receiving services, many families were as well. There was an increase like never before. The folks said that we were working with a wait list for early intervention services for 2-3-year-olds. We're at an all-time high and continue to be at a high. Luckily with our scenario, my son is doing much better now, but I wanted to identify that that was a time of stress, and being a parent's already challenging, being a new parent's already challenging. So not only do you have the frustration of the children, maybe because they're a little bit more isolated than usual and they're not, language wise, getting the skill sets that they need when they're really young. But being a parent, there's additional stressors on parents and the family system that I think really have long-term effects. So just wanted to be cognizant of that, and also say, I think that for the most part, everybody's doing the best they can, and it doesn't hurt to ask for help. And it certainly, I think, is okay to talk about it and share our stories with each other. So, all right, so I'll get off of that because that's not why I'm here today, even though I wanted to mention my own personal anecdote. But so in terms of what's happening in addiction, so I am a substance use counselor, as I mentioned before, working in the field with our substance use agencies. We have seen some very interesting shifts just for our population in general, for adults and for children. But we'll just start to dive into it a little bit here. So research has observed that there's been an increase in substance use and drug overdoses in the United States since the COVID-19 pandemic was declared a national emergency. Of course, we all know that started in March 2020. Also, there's a lot of unique challenges for people with substance use disorders and those in recovery. So, for example, those who have substance use that were dealing with active substance use during COVID, when we talk about risk and protective factors, and this is for youth as well as adults, socialization, getting together with people who are also in recovery, sharing our stories, having that physical contact for early recovery, that is critical. And now if you take that away from folks, the self-help groups, the treatment groups, the coffee hours, school, all those things that are really protective factors against relapse, we were in a bit of a struggle, right? And we unfortunately lost a lot of folks during that point in time. And obviously those with substance use are at risk for poor COVID-19 outcomes. So they might be sicker for longer because of the fact their immune systems are already compromised. So that's just something to keep in mind as well. So if we can move to the next slide, Helen. So then we put the two together, right? Like what Steve already mentioned, we have our mental health current status, our collective status, how is society doing? And then individually, like many of us are struggling. And then we have addictions, and then we put them together. And what does that look like? So according to the KFF, formerly known as the Kaiser Family Foundation, we do see symptoms of anxiety and depression have increased during the pandemic, as Steve already mentioned, but they're more pronounced among individuals experiencing some of the following: household job loss, having young adults and also women. Interesting fact too, we did see some statistics, and I could get this for folks if they're interested. We saw some statistics for white women specifically increase in alcohol use during COVID. So we definitely see, it's funny because wine and wine nights and mommy having her wine, there's these certain tropes, right, that are popular and common. And it's like, oh, it's one thing if it's heroin or pills, but if it's wine, it's fine. Well, I have to say that alcohol has been very steadily increasing. And there's obviously a lot of implications to alcohol use that our culture is not as comfortable addressing. That's just more so my own little side note, but we can definitely unpack that more if we want to. Yeah, a lot of females being, having hopelessness, sadness compared to male peers. Also deaths due to drug overdose increased. And why is this the case? Well, typically, some folks, if they're using, they use together in a group. COVID-19 and everything afterwards, the social isolation, quarantining, people were using alone more than ever before. So if someone has an overdose, perhaps in the past, they might have had someone with them to either Narcan them, and we'll talk more about Narcan in a minute, or call 911. If you're using alone, chances of death as a result of overdoses is increased dramatically. We also see that drug overdose death rates are highest among American Indian, Alaska Native people, and Black people. So that also comes to social determinants of health and some other, and being isolated and not having access to like treatment resources that all folks deserve, but unfortunately not all folks have access to. All right, Helen, if we could go with the next slide. I'm so sorry for my crackly voice. I'm going to hang in there, everybody. I'm so sorry. All right, so what's happening in mental health and addictions continued. We have a few more stats here. Alcohol-induced death rates have increased substantially. I did mention that already, that alcohol use has increased, but then we also have the death rates. So, and unfortunately, it's not always on death certificates when it comes to overdoses for alcohol or heroin. Unfortunately, sometimes those deaths are deemed by a medical examiner or coroner as a medical event, like say they had a heart attack or a stroke or something, some other medical issue that was related to their substance use. So we believe that the numbers we see are always an under report. That goes for mental health and depression that Steve had mentioned before, that 25% increase. Every number we see that are stats, just, we always want to consider that there's a lot of folks that aren't being reported accurately. And so we think that that number is always a little bit higher. Suicide deaths are on the rise again as of 2021. From 2019 to 2021, many communities of color have been experiencing an increased growth in suicide rates compared to white counterparts. Additionally, self-harm and suicidal ideation has increased faster among adolescent females compared to male peers. We see this happen sometimes with females. And unfortunately, there's a phenomenon known as Joiner's theory, which suggests that in your group, in your cohort, your social group, if an individual attempts self-harm or suicide, the other individuals surrounding them, or that the individuals that look up to them, might also be at increased risk, just because there's a power of influence there. There's a power of persuasion. This also goes for celebrities. Youth in particular, when a famous a singer songwriter dies by suicide, and the individual, the youth is at risk for anxiety or depression, or has severe anxiety or depression, and really looked up to this role model, suicide might be considered as a valid means to escape a problem. And youth don't have the same problem solving abilities that adults might have, or ability to sit with discomfort, to wait for the feeling to pass. So we do just want to, that's just something to note, is when in our society, we're seeing an increase in suicide rates, we need to be having these conversations with youth and be building up those protective factors, because they are at risk just by being exposed to those kinds of losses. All right, if we could jump to the next slide, Helen. So substance use disorder, we're just going to break down the the definitions. Things have changed over the years. We used to call substance use dependency, and abuse. We are currently going out of those definitions because abuse and dependency both have stigma attached to them. So does disorder, I think, for what it's worth, but hopefully not as much. So you'll see here, we shifted to substance use disorder, mild, moderate, or severe. When it comes to definitions, we do diagnose both adults and youth with these definitions. And it's just a classification system. So 2 to 3 symptoms for mild, you'd see 4 to 5 symptoms for moderate, and then 6 or more for severe. So what are those symptoms? Some of those examples include using more and more of the substance to get the same result. That's an indication of physical dependency. So that would be a risk factor or an indicator. Also, one's demeanor and mood changing, socially withdrawing. So maybe this was an individual who was very social and very outgoing, and now their disposition has changed dramatically. We also see functional impairment in terms of areas of school, household life, and for adults for work. So those are just some of the indicators. There's definitely more, there's a lot, and I didn't want to unpack all of that here. But when we see that more and more tend to be present with someone, then we increase the definition to moderate or severe. Here's some other examples. Feeling that you have to use the drug or alcohol regularly, daily even, or several times a day. Having intense urges for the drug. So that could be if the body starts to go through withdrawal. And also keep in mind this relates to alcohol. It also can relate to something like cigarettes, right? Which we're also seeing that youth are having a big increase with vaping, and we'll talk a little bit more about that in a while. Over time, you need more and more of the drug to get the same effect. That's that tolerance that we mentioned before. All right, if we could skip to the next slide. And then here are some other of those warning signs or risk factors: problems at school or work, physical health issues, lack of energy and motivation, weight loss or gain, physical indicators such as red eyes or changes in pupils. Those are all things to look out for. If someone is under the influence of opioids, their pupils are usually going to be pinpoint or small. Neglected appearance, maybe someone typically took care of themselves and now they have a lack of interest in clothing or grooming. Now keep in mind that could also be an indicator of mental health, anxiety or depression symptoms. A lot of these symptoms tend to go together, and it's hard to tease out what is what, and sometimes certainly it's both. Changes in behavior, so major efforts to bar family members from entering the teenager's room, stay out of my room, I don't want you in here. Being secretive about going out with friends, and dramatic changes in behavior and relationships with those family and friends. Also having money issues, that applies less to youth, I think, and more to adults, but it's another thing to be, unless you find that there's things being taken out of your home, stolen from your wallet. And this goes for medications as well. Just to pause for a second, we always want to encourage parents, obviously, to lock up their medications, even if you think your youth is not at risk. Again, we want to consider peer pressure and the conversations that youth are having with each other. There's a lot of talk right now in the school systems and in the youth community about mixing pills and what pills can do, and having a little high to get through the day, or having a little adrenaline pump. A lot of times youth don't know what they're taking, but they're curious. And so raiding the medicine cabinet, or even if a friend suggested, like, I found this in my mom's medicine cabinet, do you guys have this? These are conversations that happen regularly. So it's really important to be cognizant of where your medications are. And we'll also talk about drug take back days in a little bit. That's another thing to consider as well, if you have youth in your home. All right, Helen, thank you. So we'll just break down real quickly what are opioids. I know everyone probably knows what opioids are already, but they're, pretty serious business. So we like to spend time on them. They are a class of drugs that is historically used to reduce pain. They also have a very sedating effect. So people tend to feel calm when they're on opioids. They feel more relaxed. Sometimes people with anxiety or depression gravitate towards opioids because it is mind and mood altering, and it might provide them some relief from what they've been feeling emotionally. So prescribed opioids can be given by doctors to treat moderate to severe pain, but they can also have serious risk and side effects if not taken as prescribed. And then we just gave on the bottom of the slide there some examples of opioids. I'm sure we're familiar with the names oxycodone, hydrocodone, morphine, methadone. Those are all opioids that are prescribed for pain management. All right, Helen, if we could move to the next slide. And fentanyl, I'm sure that folks have heard a lot of buzz about fentanyl as of late. Unfortunately, fentanyl is a very, very dangerous synthetic opioid pain reliever that's about 50 to 100 times more powerful than morphine. So morphine is one of the most powerful opioids out there. Morphine is used for hospice care, for severe pain when nothing else can be, cancer patients, folks who are really, really sick get morphine, and then fentanyl is the big brother to that. So it's really scary because it's also very cheap. And so drug dealers, individuals in our community that sell drugs, they are putting fentanyl into the supply sometimes to increase their bulk because it is pretty cheap and increase the power of the drug. The problem with fentanyl is that it's rapid onset and short duration. It can begin to appear, it did begin to appear in large quantities around 2013. So we've seen it in our drug supply, but we're seeing it boom now significantly. It can be mixed with heroin. It can also be mixed with fake pills, which youth really are gravitating towards nowadays. We can also find it in cocaine. So it's not just heroin. It's not just injection heroin, but I also want to say that there's also an inaccurate fear base around fentanyl in youth. You would probably most likely see it in fake pills, not necessarily cannabis. There's a lot of rumors out there that fentanyl is in cannabis. The burning point of fentanyl is lower than cannabis, meaning if you do smoke cannabis, and it has fentanyl in it, the properties, the active properties of fentanyl are going to burn away long before you get the high of the cannabis. So that's actually a protective factor because a lot of the youth are smoking cannabis at increased rates right now. I'd be more concerned about the pills at this point in time. All right, so let's move forward. And then to top it off, we have xylazine. This is just I won't spend a lot of time on this, but because it's trending right now and we are seeing this in Schenectady County, I know we have folks on the call or on the Zoom that might be from other counties, but across the board, counties are starting to get hit with xylazine. This is a non-opioid veterinary tranquilizer that we are sadly finding in our drug supply. It's also known as Tranq. That's its street name. And it has increased the number of overdose deaths nationwide. Unfortunately, it does not respond to Narcan because it is not an opioid, but it is found in opioids as well as cocaine and other drugs. So we are concerned about xylazine. In Schenectady County, we're actually developing a response system that involves hopefully increasing drug testing our supplies more often through Project Save Point Catholic Charities, so that we have data on what's in the drugs and what we can do about it. We also have fentanyl test strips, and I've heard recently that there's also xylazine test strips that we can try to get. And we want to give those to drug users, so to encourage folks to test their supply before they use. Which I just want to pause there. I know what I just said is kind of a big statement, depending on the mentality and philosophy of folks, and depending on the culture of where we're at and who we're presenting to. People, I want to recognize that people have different perspectives on harm reduction. The field of addiction is moving more in the direction of harm reduction, meaning we're meeting people where they're at. We're not necessarily telling them that they need to stop their drugs right away. Because we know that the reality is people don't always stop using right away when we tell them to. So we're trying to be a little reality based But certainly when we're talking about youth, that's a lot different, right? Because these are minors, these are folks that should not be ingesting drugs and alcohol. So when I say harm reduction, I'm mostly referring to adults. Yeah, that's just part of the conversation as well. Helen, we can move to the next slide. So what is naloxone or Narcan? So that is a medicine that stops the effect of opioids. So that could be pills or injection heroin or intranasal, drugs that are snorted. It can push most opioids off receptors in the brain that cling on to opioids and blocks them for 30 to 90 minutes. So essentially what this means is when someone is overdosed, opioid receptors sit on receptors or the opioids sit on the receptors of the brain, and then that prevents someone from breathing. It essentially shuts down your central nervous system. Narcan will bring the opioid off the receptor so that the person's system can be relieved of that, that's suppressing them, and breathe again. So Narcan works for 30 to 90 minutes and then it goes away. And then if there's still opioids floating around, then they'll go back to the receptors. So I just wanted to share that's we still want to stay around someone who's overdosed because they might be at risk for re-overdosing once the Narcan wears off. Helen, if we could go to the next slide. So one thing that I always like to suggest is get trained, be part of the solution in our community. The more folks with Narcan on them, the better, because sometimes youth also need to be Narcan. The school systems do have Narcan on them that are local in Schenectady, and they've had to use them a few times this year. So we encourage everybody get trained. If you're a parent, have it at home. It doesn't hurt. There's no stigma associated with it. And if God forbid you give someone Narcan and then it turns out they didn't need Narcan, there's no ill effects because of the property of the medication is literally just to move the opioids off the opioid receptors. That's literally all that's in the medication. You can get trained if you're a Schenectady County resident, you can get trained via our website. And I did put the link here and we could certainly share that in the chat and in emails with folks later. You can also just contact me directly if you want a training or a kit and we'll get you hooked up with that. It's confidential, it's easy. There's no harm in having it. And also when we do the training, we go over some other information about opioids so folks can increase their knowledge base on that. All right, Helen. So in terms of youth and what we're seeing on the youth end for youth 0 to 17, I did put some narrative data from Ellis Hospital that we've received through our data system. So we have some crude data that suggests about 5% of drug-related hospital visits were accounted for by youths in 2022. I think Steve mentioned this before, of course, with our data, we're always like a year or two behind, not always sure what's happening right this very minute. But 2022 is pretty recent data. So narratives from Ellis Hospital commonly reflect that accidental overdoses were on parent medications or on over-the-counter. Sometimes we did see some narratives suggesting that folks ate something like a dessert or brownie that they didn't know, that they say they didn't know had it in them. But for the most part, we have accidental overdoses. Like kids don't want to overdose, they just want to try to feel better, try to feel the high. And so they take something and they have no context. You know, sadly, individuals that have been using drugs for years are actually a little bit safer than kids sometimes because kids don't know the context. Kids don't understand how much to take or when and why. And then there's a little bit of invincibility, like, oh, I'm fine. You know, this isn't, you know, let's just experiment with this. My friend did it and they had a great trip. Kids are way more at risk, I think, than folks who have been doing this for a while. So we really want to be having these conversations with them about accidental overdose and how that's a real factor when kids are using. All right, so we'll go to the next slide. So just a brief note on marijuana. I've been talking for a while now. I'm going to pause. Steve, do you want to chime in at all? I know we're going to go back to you in a minute, but I just wanted to take a pause.
For First of all, you sound great. Your voice sounds great, Jen. And
You're
I'm
lying.
no,
Thank
it's
you.
true. And I'm I'm learning a lot. I'm learning a lot. It's wild. Um, I wanted to, if I could comment about, well, two things. One, I was fascinated with the overdoses are not listed on death certificates. I thought that
Not
was
always.
very interesting. Yeah, not all. Okay, yeah, I just thought that was just very interesting.
Mhm.
I was thinking that with a subjective thing I wanted to add from the beginning when you were talking about um, alcohol increased use during the pandemic and the shutdown for women and white women. What I was interesting is I was thinking that the stigma can work both ways. I know very honestly for myself, my alcohol consumption increased during the first year of the shutdown. I
Mhm.
told my doctor, I told anybody who was listening, because in a practical sense for me, I just thought, where am I going tonight? I'm not going anywhere.
Right?
So if I want to have a beer at dinner
Yep.
or two beers after dinner or whatever, I really didn't. I'm like, there's no consequences here. Like, there's no pragmatic problem here.
Yep.
But that's about as far as the thought went, at least as I recall. So I think like the stigma for me was like, well, there's no stigma. I don't have to worry about it. Number one, who am I talking to about it? Like, you're all
Right.
home alone, but didn't really think about how much if you're doing that if I'm doing that 4 or 5 or 6 nights a week, which I was not doing before the shutdown,
Right.
So yeah. So anyway, that's all. Everything has been great. I just wanted to share that I think it's very insidious for a lot of us, and we have to
Yeah,
be very cautious about it. Just because it's legal doesn't mean it's not harmful. That was
that's
what came
right.
to my mind. But that's all I got. I'll shut down until I'm ready to come back. But thank
Okay.
you.
No, Steve, I really appreciate your perspective and your honesty. I think it's always helpful when we can share our own experiences, and kind of like normalize the conversation about like, oh, maybe I was doing a little bit more than I should have. And because I think many of us have been there and done that. And just saying it out loud kind of like disempowers the stigma and points out we're all human, and we all have jobs to do and multiple things to do. But like when we're under severe stress, things are possible for any of us. And, if we're having some things and we have all these protective factors, think about the folks who are in disadvantaged situations or have lost their job, or, it's just kind of wild to think about, right? Is that things could go from not so bad to bad kind of quickly. So thank you for that. I appreciate you sharing that. All right, so let's kick it over to cannabis. This is a conversation that everybody wants to talk about because it's legal now in New York State, for adults only, of course. That's 21 and over. People 21 and older can possess up to 3 ounces of cannabis flower or 24 grams of cannabis concentrate. So an example of that is edibles or cannabis oil. Although it's currently legal, treatment is still recommended for those presenting with problematic substance use disorder. I feel like that's obvious, but I had to say it there. And just from the perspective of a substance use counselor, oh, this has been hard. Because there's people that use cannabis, problematically. And I think what we're seeing now is a trend that cannabis is okay. The general idea of cannabis has always been it's okay, it's safer than alcohol, it's safe, it's fine. And for some people, for many people, certainly, yes, that is true. Some people use cannabis to help with their mental health and depression, or physical ailments, concerns. Cannabis has been very effective for cancer treatment, alongside cancer treatment, to help people get their appetite back when they're going through chemo. Can also help with eating disorders. It can help with a lot of things. However, cannabis can also cause problems, just because, again, anytime you're talking about changing the chemistry of your brain and taking in a mind or mood altering drug, we just want to be aware of that and be having the conversation, like, what is this impacting on me? We're self-monitoring. We're really, listening to feedback from friends and family members. Am I am I changing, or is this okay? How much am I doing? How much am I doing it daily? And when it comes to youth, we have to draw a hard line. I think that cannabis, we can't support cannabis smoking with our youth. We also understand, though, that it's happening at a very high rate. So when it comes to youth and youth developing minds, cannabis is not a protective factor. Obviously I feel kind of silly saying this out loud because I'm sure everybody knows that, but I feel like I have to say it out loud, right? Like, just like nicotine or any alcohol, any drug, any mind or mood altering substance, we just want to navigate those conversations with our youth carefully. Driving under the influence of cannabis is still illegal. Operating heavy machinery, we don't want kids going to class being under the influence, and certainly we know that's happening right now. There's a great organization called the Office of Cannabis Management that does put out a lot of helpful information. They do a lot of myth busting. They also talk a little bit about youth and how are we supposed to navigate these conversations with our youth right now versus adults. So I put that contact information below. We highly recommend people reach out to them because they are the experts right now in current legislation and trends, and how are we having conversations about cannabis in New York State. All right, so we can move to the next slide. I'm going to talk a little bit real quick about youth and vaping. This is the hot topic. The use of e-cigarettes is unsafe for kids. It's unsafe for teens. It's unsafe for young adults, and it's unsafe for adults. However, everybody's doing it. And of course, there's the amazing flavors that come with e-cigarettes that are really enticing to youth. You have blueberry pancakes and Bananarama. I don't know. There's all sorts of different flavors I've heard out there that youth, heck, they sound good to me. So I'm sure they sound good to, impressionable youth. But just to note, most e-cigarettes contain nicotine, and nicotine is that highly addictive and property and can harm adolescent brain development, which continues into the mid-20s. Our brains are our power and our everything. And if that's compromised, then sometimes you can't get some of them back. The brain is also elastic. It has a lot of elasticity. Sometimes you can retrain your brain, but again, you're putting your brain in a compromised position when you're using drugs and alcohol, especially when it's still forming. And we also like to keep in mind that e-cigarettes often contain other harmful substances besides nicotine. It's not just nicotine. So people always say too, when it comes to smoking, things like, oh, cannabis. Let's talk about cannabis for a second. Cannabis is natural. So the properties in cannabis might not be as harmful as smoking cigarettes that just have all bad chemicals in them. So smoke in general, though, which is created when you smoke cannabis, is obviously going to impact one's lungs. It will burn the cilia in your lungs, preventing your lungs from being able to push out infections. Those are the little hair-like follicles in your lungs that push out bad things, foreign entities that are not supposed to be there. The more that we smoke, that just kills all of those cilia hairs. And it doesn't matter what you're smoking. If it's smoke, it's damaging your lungs. So always like to put that perspective out to folks as well. Young people who use e-cigarettes will be more likely to smoke cigarettes as well down the road when this is no longer as trendy. So let's go to the next slide, please, Helen. All right, services for mental health, developmental, and addiction. I believe now I'm turning it back over to Steve. So I'll take a little pause and I'll kick it back to you. Thank you.
Great. Thank you, Jen. That was really, really, really informative. Really great stuff. So what time is it? It's we're an hour and 13 minutes into this training, and we're just getting to the main title of services. So I didn't put this on the slide, but I wanted to say, first of all, that networking is huge. So if you're working in the field, or if you're a family member and you're looking for how do I get help for my kid, or how do I get help for my family member that's an adult, or we're going to focus on kids today. with the special ed task force part of this and students, but networking is big. So whatever you do for, we used to have Rolodexes, now we have cell phones and whatnot and email, but just try to have a folder you file away names of people and what they do, even if it's not something that if it's not something that you're looking for. I'm not looking for addiction, I'm looking for mental health, but I remember Jen was great at this training. Just reach out to her and you'll be surprised that one provider can help you find other providers and whatnot. That's a huge, I believe in that very strongly. So networking is huge. Now, I've listed a few things here that where you can start to look to get services. I believe every county in New York State has a SPOA coordinator, a SPOA program. Okay, we're going to go through that and not yet, but when I get to the next slide. There's care management. There's something called Children and Family Treatment Support Services. There's something called the Home and Community-Based Services. Those three, the three before, right after the SPOA piece, is usually, it's a good starting point if you don't have any info about how to get help. It's usually for youth that have Medicaid or managed care for their medical insurance, but it doesn't have to be. We have some waiver type programs to kind of, it doesn't have to be the case for that. I know I have some of my colleagues on this call that are supervisors of care management, and they're probably starting to get a little shuddery right now saying, Steve, you're not getting it right. So I apologize about that. But if you have better info, you can just put it in the chat and we can share that with people. Another service that is out there is crisis stabilization, hospitalization. We're going to get to that. When I say hospitalization, I mean psychiatric hospitalization. There's, of course, therapy, outpatient therapy, and there's addiction services, inpatient and outpatient for addiction as well. I am guessing that the addiction piece, based on something that Jen had said a few minutes ago, it's broader than what it used to be. I think from my generation, it was all about, what's the right word? When you don't have any, the treatment was, the recommendations were stop using alcohol, stop using drugs. And then I'm thinking with the inpatient, yeah, Jen, go ahead.
So
Yeah.
that would be like an abstinence-based model.
I couldn't
You
think of
got
the
it.
word. Yes, abstinence. I knew it was an A word. Thank you, Jen. Right. So it sounds like, and I've been hearing this before today, that the addiction community and the treatment for that is growing beyond that. And that's what Jen has referenced earlier. So I think there's a broader swath of outpatient type services as well as probably inpatient. Another thing real quick before we move on to the next slide is, I think again, let me just speak from my own experience and where I stand in, oh my God, I want to just hold on here. I just got a notification on my laptop about wanting to reboot my computer without my permission. I'm saying no, but God forbid if I get cut out here, Jen, you might be on your own.
I'll be ready. I'll be on standby.
I get nervous
Steve.
when I see that because it asked me a
Yeah.
couple times. I keep saying no, and then it does its own voodoo.
That's nerve wracking.
That's bringing me anxiety. So
don't worry, because if you go, then I'll be right here we're all ready.
Okay, all right, thank you. So but I think from my own experience or representing kind of middle class and certainly white middle class, when your insurance is usually through your job. So if your kid needs help, then you say, well, where can I get therapy for them? I think they need therapy. So I'll call my insurance or whatnot, or someone that takes my insurance. So that's fair and that's great, but that doesn't help access for people that don't have that ability or that access through their job or whatever else. So that's one way you can do it, but that is not everyone in the community. They need all these other things as well. And there are middle-class people that need these services because of the level of intensity of the mental health or the developmental stuff or the addiction stuff. So anyone can access it if you need this higher level of service. Okay, let's move to the next one. Thanks, Helen. So SPOA, all right, so SPOA, it's single point of access. So the idea is you go to one person in your county and you say, I need help for my youth. I need help for my student. School districts cannot access the SPOA coordinator, like they don't have consent for that, but they can give information to the family and to any other providers that's working with the family, with the school, and say, maybe you can call the SPOA coordinator. We have the name and number here. We have an email, so you can get more help for your youth. I would think that would be helpful. But anyway, the idea is you go to one person, and I'm just going to read some of this just because it's important to go through. The SPOA is a process. So local systems in like the county in this example, try to really coordinate cohesive services to help individuals. So what happens is the SPOA coordinator does not do the care management. They don't do the coordinating, but they will kind of reach out on behalf of the family once they interview the family and say, okay, what kind of help do we need here? Or they ask the parents, what kind of help do you think you need here? And we'll help you find that. And then you get access to, usually care management is one of the main first things because they will do coordination of services. And as you see here, so that's really important because if you have more than one counselor treating your child, you definitely want coordination of services. You don't want one therapist saying something to your kid and a different therapist saying something else to them or to the parents. So care management is really important and coordination is important through that service. It says here, which I actually didn't know this until I did this research. There's 3 types of SPOAs. There's for kids, I knew that. There's for adults, which I knew that, and then there's for adult housing as well. I did not know that. I know very little about that, but the idea of adults need housing, you can find a SPOA coordinator to help with that. If you're a web surfer, you can go to your county's website and should be able to find info on that. And if you can't, network.
Steve, can I just add something real quick?
Absolutely.
If folks want to do SPOA services through Schenectady County, you can just email me and I can link you to the right person depending on adult or children because they're through our office. So I'll put my email in the chat.
Thank you, Jen. That's very, very helpful. I appreciate that. New York Connects is another service. I think that is on our New York State website, probably under the health department, but I didn't cite that, so I'm not exactly sure. But they refer to themselves as being your trusted place to go for free, unbiased information about long-term services and supports in New York State for people of all ages with any type of disability. So I wanted to mention that if you're Googling that, like that just seems like a very broad and helpful place to start. If you go away from today and you lost this presentation, and just Google New York Connects, and if you can't find something there, go to the New York State website for the government and maybe the health department, and then search for New York Connects, and that would be a good starting point to find services. Okay, Helen, let's go to the next one. I think I covered care management pretty well, so I'm not going to read this one over, but the whole idea is they don't really provide it. The only service they really provide is coordination. So sometimes you have a therapist, sometimes you have a family support worker like myself, helping with advocacy and emotional support. Sometimes you have, I'm going to get into more services in a minute. So you have other services that the care manager puts in place. And it's really important. There's a structure to kind of have that coordinated. I forget if it's every 90 days or maybe twice a year. I don't know for sure, but there's structure to that. But also a good care manager is not waiting for those meetings to occur, those every 90 days or every 6 months. They are keeping on top of things, engaging with the parent and the youth, and trying to keep that document kind of a living document. So this youth, as their needs change, it gets addressed through the services that are being provided. Okay, so that's pretty helpful. Oh, and I should mention that these are not, they don't cost you anything. If you get them, as we're describing through the SPOA process, there's no cost to the family. Okay. Okay, there you go. I think I'm ready for the next slide. I hope. Okay, so care management, what I'm referring to today is mostly the care management provided through the SPOA. That's really for mental health. If you have a student or a child with a developmental disabilities, you would be going to the Office of People with Developmental Disabilities, OPWDD in New York State, as opposed to going to the Office of Mental Health, which is OMH. So they're a little bit different. So you don't have to, I don't think you have to really know what you need. I think you need to know what's going on as much as you know about your youth's issues and their diagnoses and whatnot. And then you would go to somewhere to the care manager and then, or to the SPOA coordinator, and they would help decide. There are many cases where we have kids that come through SPOA through mental health. And as we begin our work, we quickly see that this might be a person with anxiety, but they also might an ADHD, which are mental health diagnoses, but they also have autism, or we help the family get that diagnosis if it's valid. And then from there, sometimes we're like, you'll be better served through OPWDD. So we'll help you get to that system. And then we'll probably we'll back off and discharge so you get the proper help for your youth. Sometimes we need both systems. That does happen as well. And as I referenced before, it's provided for people with private insurance as well as Medicaid, the Medicaid for insurance and managed care. Okay, let's keep another one, Helen. Okay, so CFTSS. So this is for kids and youth under the age 21 who have Medicaid, okay? And if they have either mental health or substance abuse needs, they can get CFTSS. If you know enough about it, you can ask for that. Or a lot of times our families just go to the SPOA coordinator and the coordinator will help them figure out if it's appropriate for their youth to get this service. They'll have their individual needs met. And I say that in terms of what their mental health and symptoms and behaviors might be. Obviously, we've learned, most of us already know that the earlier we can get this done, the better. The younger the youth is, the better. But sometimes we get students that are, 14 years old and they've not been really treated for anything. Maybe they have a late onset of mental health issues, perhaps. But the whole idea of putting these services in place really is to meet individual needs of the individual youth, get the proper services put in place, and the belief and the philosophy is by doing that, the whole community is going to help this family decrease the amount of times they have to go to the emergency room for a mental health evaluation, or decrease the amount of times a student or youth needs a hospital stay, a psychiatric hospital stay, or a residential placement. In other words, placed out of their home in a group home somewhere. The whole philosophy of doing this is this will decrease all of that. Just want to keep an eye on the time. Okay. And under the CFTSS, these services I'm going to tell you now are available. Therapy, which is typically talk therapy, okay? Maybe play therapy, but not every therapist I've learned does play therapy, even when they work with youth. Usually it's for younger youth, 5, 6, 7, that kind of thing. But it can be effective, I think, for any youth if the therapist does that. But otherwise, it's talk therapy. That would include assessments, like mental health assessments, kind of giving us an update and a rundown on what current and what maybe other diagnostic mental health issues might be there. Rehab services, which includes generalization of therapy goals. So when a kid's working and learning on something in therapy, if they're working on coping skills to manage their anger, it's a very common, everyone's aware of that type of thing. The idea is part of the rehab service, I think, is to help them generalize, take kids out in the community or even work in their home as opposed to the clinician's office. Also learning new coping skills. And I think it's undervalued how important that rehab can also work on self-care and improved relationship skills. So Jen referenced earlier, self-care might fall by the wayside, hygiene and whatnot, because of mental health issues or drug misuse and issues and alcohol misuse. So I think it's really important, to address that when necessary, and especially before it gets really bad, like kids not showering, it's been 3 weeks. it'll be easier to get them going if we see signs of that first. And then, of course, another service is family peer support, which includes advocacy, which is what I reference as my job. Help. That's really there. Most of the services are for the kid directly. Family peer support is for the parents or the guardians directly on behalf of the kid. Okay, next one. Thanks, Helen. So home and community-based services are not the same as CFTSS, but they're really similar. I'll again leave it to my colleagues on the call that are aware of this. They can put something in the chat, or we'll have time for questions or comments in a few minutes. But it's really the same type of thing. Put services for the youth in their home and in their community and help them work through their current goals under their diagnoses that they're working on. We want kids to be successful both in their homes and schools and out in the community, because any unsuccessful experiences they have will not help their self-esteem and not help them to grow more. So we want to work as much as we can to have those be few and far between, those not successful times. So HCBS can help us help the kids and the family really work together with all the teams that are in place, and so that and whatever's most convenient for them. So a lot of times coming to the house is the most convenient for some families. So that's where we'll do it. If we can bring them out in the community, in public, then we'll do that too. And again, HCBS offers flexibility, so that the idea is to work around the family's schedule, not our schedules. These are not 9-to-5 services. You know, they're usually after school, sometimes even early in the morning if a youth prefers that before they go to school. Great, Helen, next slide, please. Okay, hospitalization and crisis stabilization. So hospitalization is when you have psychiatric needs that are very intense and acute. And I will say, from a layperson perspective in this field, it is very difficult for years now to get kids into the hospital for psychiatric intense services. The good news about that is, you know, we're trying to work this model of having these services in place in the community so that we don't have kids in the hospital. We don't want them in for 3 weeks or a month, and years ago, kids could be in there for a long time, as would adults. So that's the good news. But the downside, in my opinion, that I see professionally is that youth really, you know, have to really be either have a plan for being suicidal that they're going to follow through on before a hospital will admit them, or that they're homicidal, that they have a plan to hurt somebody, like a real distinct plan, before a hospital will admit them. It's very rare in my experience that anything less than that will get a kid in the hospital. And sometimes, and again, in my opinion, sometimes kids need that. Sometimes we need a 7-day stay at a hospital. They need to be removed from the community to kind of get reset. And what hospitals will do is look at the medication piece. So that's what their main job really would be while the kid's in the hospital. So that's great, but you know, we used to be able to get kids in a hospital for what we call a planned stay, so that they could be in there. We're going to admit them next Friday for a week, so the doctors and the nurses can take them off medication and keep them safe, and then try new medication or different doses or whatnot. And those are extremely hard to get now. So that's kind of the downside, I think, with the hospitalization part, that we don't get it for as much as we need, but it is out there. And downside for parents is they get tired if they keep bringing their kid to the ER for very severe behavioral unsafe symptoms. And then when the kid's there for 6 hours in the ER, they calm down. The hospitals say that they're fine, which they are at that moment, and they send them home. So that's a little bit of a frustration for families. Crisis stabilization is defined as a direct service that will assist de-escalating the severity of the kid's distress or his need for urgent care or acute care for both mental health and substance use. We have, I know Northern Rivers has a crisis stabilization. I think we have 2 programs. They're residential, but they're short term. One of them for the younger kids up to age 12 is up to 3 weeks. very rare it's longer than that. So it's a very finite thing. And then it could be less than that. And then the other ones for the older kids, age 12 through 17, I believe, maybe through 21. And I don't know if there's a set stay period for that, but again, it's usually short term for crisis stabilization. The whole point is we just want to help them kind of reset themselves, or we will help them to reset both, but maybe looking at medication, certainly having more staff on hand to help them deal with what they're going through. It's easy to look at these kids and be like, they're just being behavioral. They just need to focus and they just need to stop hitting people. That's a very simplistic view of what they need. That's what I'm just going to say that it's just very simplistic. It's 12 to 17. Thank you, Sarah. So I think one of my cohorts there. For our older kids, it's ages 12 to 17 for the crisis stabilization program. So it's just very simplistic to look at it like that. So we have to realize you have a kid that's in mental health crisis. It's not like for an hour. It could be for weeks or longer if things don't change for them. So to just say they just need to straighten up is very naive and simplistic. Okay, next slide, please, Helen. I think I covered therapy and counseling. Usually every county has a clinic that you can provide for anyone that wants it, but certainly for Medicaid clients. A lot of times if you have private insurance, you have to find a therapist, and usually your insurance will help you. They'll tell you where you can go. And there's private stuff as well. Okay, let's move on to the next one, because I know time's running a little short. I want Jen to be able to finish. Oh, there you go, Jen, we're on to you. I just want to point out we're at 11:36. You know, our goal is to get to questions, or if anyone has any, in about 10 minutes. Jen, if you're not done in 10, I think that'll be fine. Just keep an eye on what the time is and whatnot, okay?
I think I can do this. Steve, in 10 minutes. Here we go. All right. Thank you, Steve. So we'll wrap up a little bit talking about addiction help and how do I get started. So there's always OASIS, which is now the Office of Addictions Services and Supports. It used to be the Office of Alcohol and Substance Abuse Services. So if you'll notice, they changed to more trauma-informed language. So they're addiction services and supports now. So here's some links for them if you're interested. Also, SAMHSA is always a really good resource for mental health and substance use if you're working with folks who have dual diagnosis. And we can go to the next slide, Helen. Thank you. So here is just an example of a flyer for OASIS and the HOPE number that they suggest calling. We always give this number out to folks but also remind them it's a New York State number. And so if you need something a little bit more personal, we always want to recommend folks link into their local resources as well, which we'll go over for Schenectady at least in a minute. All right, all set here, Helen. So drug take back days. I know I alluded to this before. There's opportunities in the community to bring your unused medications, anything in your medicine cabinet that you're not using anymore, whether it be a controlled substance or otherwise, because people can do a lot with medications that you think wouldn't have much value. So just anything that you're no longer using, we recommend that you bring it either to your local drop box or get on a mailing list for when the drug take back days occur. So they're twice a year. They're typically in the spring. There should be one coming up actually. And then there's typically one in October. So if you're interested in that, just let me know and we can put you on a mailing list for those days that are coming up for Schenectady County, at least.
Jen, can I interrupt and ask a question? I'm
sure.
sorry to take more of your time.
No, you're
good. So in this slide in Schenectady County, so are you saying you can use those drop boxes anytime?
Anytime, yes.
And is it better to call ahead and say, I'm going to bring some? No,
you just go.
Just show up and bring your stuff and drop it in the box.
It's totally confidential. I've also been told you can take old Narcan kits and bring them, but I have yet to confirm that with the actual disposal locations. They say they don't know.
Okay.
Then we'd have to contact this. Yeah, I don't know.
Okay. Thank you.
But I think if you're not sure, it doesn't hurt to do it because they'll take a lot of stuff. So thank you, Steve. That was a good question. All right, Helen, I think we're good. All right, so this is a lot of information. So I think we're sharing these slides with folks afterwards. Yeah, so I'm not going to go over all of this now. Just wanted to make note that there are some great resources in Schenectady County that we recommend folks be familiar with if you are in Schenectady County or referring to Schenectady County. These are our big partners that we work with regularly. Conifer Park, New Choices, Ellis, and then our Catholic Charities and Conifer Park. And then we have more on the next slide if we can move over to that. We also have St. Peter's Addiction Recovery Center. There is a Rotterdam location. Hometown Health Schenectady is great because they're primary care, but they also do behavioral health services. They're kind of like a one-stop shop for a lot of things. So we recommend them highly. There's also the Schenectady Cares program at the Schenectady Police Department. Northern Rivers has mental health services, including crisis services that we talked about. And then there's the living room that's located in Ellis Hospital, Ellis Outpatient on 1023 State Street. So if anyone has questions about any of those resources, I could break that down further for you. But for right now, we'll skip ahead. Outpatient services for adolescents, always important to talk about what do we do if individuals need treatment. There's New Choices Recovery Center, Community Counseling. Anna Hauser is the program director over there. She's amazing. I always like to sing her praises when I get the opportunity to, because she works with adults and kids and families. They have a craft program for families. They also do assessments for youth under age 18. They do individual counseling. They also have peer support. They're just a great resource to know. I highly recommend them if you're working out of Schenectady County. Next slide, please, Helen. And then also, if we want to get ahead of things, which is my formal recommendation, I guess, is that we're always talking to children before it becomes a problem, that kids are equipped with information and education, regardless of learning level. There's conversations you can have with youth who might even have developmental disability. There's different kinds of ways you can navigate conversations. OASIS has some great material on that. And the prevention department through New Choices has some great materials on that too. So they have a lot of evidence-based programming. They go into our local school systems and teach kids about drug use and also feeling management, which is something that our youth and we all need right now, probably. So you can contact New Choices Prevention, and their contact information is below if you're interested. We'll keep moving along here. St. Joseph's is also a great resource. They have a rehabilitation services for youth, and the contact information is below. They are pretty comprehensive in that they have access to a pediatrician, psychologist, psychiatrist, mental health, and substance use disorder. So if you're at that level where a kid or youth needs detox or rehab, these folks are a good way to go. All right, next slide. What can we do to help our community? I know we already talked a little bit about getting Narcan trained. We can also learn more about and promote the message of harm reduction. Even if it's something we're not comfortable with, I think we all would benefit from learning about a little bit more about what harm reduction is on a wider scale. Technically, the following things are also considered harm reduction: wearing a seatbelt when you're driving, wearing a helmet when you're wearing a bike, putting sunscreen on when you go out in the sun. So like, even though harm reduction, I think, gets a bad rap by itself, we technically apply harm reduction techniques every single day. So I think it's just about changing the narrative a little bit so that folks feel like we can have conversations with them about substance use. And then I put my contact information in the chat and also below if folks have any additional questions. And I think we're almost to the last slide. Steve, do you want to do this first?
Yeah. First of all, that was all very helpful. I also want to say, I think I saw Helen put this out there. So I believe we would really like for people who are here today to fill out a, oh my God, Helen, an assessment or an evaluation of today's training. It really helps us plan for next year, us at the task force. So be honest, be frank, let us know what you needed still. If it wasn't good, if it was good, we really take those seriously. So make sure it'll be online. You probably receive it right after the training today. So try to do it today and get it back to us. We really would appreciate that. Okay, learning, so wrap up. So similar, really the same points, I think, I kind of listed these out there, but learn and research and become aware of what's happening out there. So the whole first half of this training, you don't have to do all of that, but it's good to be aware of what's actually happening currently when you're thinking about trying to get help for your youth, okay? Try to learn about services in your county and community. Again, I'm going to push for the networking thing. You know, I once had, I have a brother-in-law who once said he never learned, I mean, this is 30 years ago, you know, before cell phones were really big. He said, you know, I don't learn phone numbers. I just write them down. So I don't have to learn them. I just look them up. So I think that that's the same thing here. Just keep a short list or a long list of people saying, gee, I don't know what I need, or I need mental health, but I don't have Steve's number. I'll reach out to Jennifer. She'll help me find something. So networking is really, really big. Okay. Similar to one of Jen's last points, I think, don't be shy or embarrassed. Just ask for help. Many other people suffer, and you're not the first person who needs that help. So just reach out for that. I need to take a 1-minute break, but we're not done. So Helen, if you could maybe lead us into questions, I'll be right back.
Yes, definitely. If anyone has any questions, you can put them in the chat, or I invite you to unmute yourself and ask the question.
I want to remind everybody, this is Regina Perry, because I'm the community services manager for Northeast, or that CFTS services and HCBS services are a voluntary program that the family needs to participate in. SPOA can make the recommendation, and like my grandmother used to say, you can lead a horse to water, but you can't always make them drink. So some families are resistive to us coming in there because they look at us as more of, you know, kind of like CFTS or like CPS services, and that's not our goal. Our goal is to assist families in having a successful child in their home. That's our goal, and to keep them out of the hospital.
Yes, Regina, I'm back. Thank you, everyone. I'm so sorry. Yeah, I saw your comment. I was going to bring that up. And I think another point I just want to add to that, and that's kind of the finessing of work that we try to do in human services, I think. So yes, you know, the idea, like any programs overseen by the Office of Mental Health in New York State, it's all voluntary, meaning the youth and the family have to agree to the service. They have to say, okay, I'll do that. And, you know, from a clinical perspective, that makes all the sense in the world. You know, the best therapy happens when someone's ready for it, when they're ready for a change. The problem I see with that is we like Regina's sharing a very, very important information. However, I feel like that should, and I know this doesn't happen, but I want to point out to everyone, like that shouldn't be, it can't be as simple as, well, do you want this service? And the family says no. You say, okay, we'll see you. You know, it's, again, that's a very simplistic view. And a lot of what we do is we try to engage with the family, build some trust, which is difficult, as Regina referenced about CPS. It's hard to trust if they think, like, it's hard for families to trust CPS. And we're not CPS, but they might feel like we're just another provider that's going to call CPS on them just because. So we have to work with families that kind of help develop that trust so that they will want the service or that they will see benefit to it. So anyway, I just wanted to add that to what you said, Regina. Thank you.
Right. And we gently remind the families we are mandated reporters, but we also at the same time say, listen, we see this. How can we help you and assist you so that this is not an issue and we can resolve this so it doesn't go further than this?
Right.
So we really are more of a support service. We are not, a penalized service. That's what I want people to understand. And sometimes that comes across that way. And I'm not saying that every SPOL committee does this, but that's the way we would like to be presented, is that we are more of an enhancement for your family.
Absolutely. I agree. It's about how the process occurs. Thank you, Regina. I appreciate that. Helen, I've not monitored very closely. So is there more in there in the chat, or do we open up for people on the phone for questions?
I see here it says, does anyone recommend any good educational resources for families and parents of children or adults who deal with mental health struggles in addition to a developmental disability who are at risk for substance use disorder? And
my first, what I always tell parents is like, the first thing is to go to whatever provider you already have and ask them. That's my first thought. All right. So a lot of times as things are starting up, families will go to their pediatrician, which is great. I think that's as good as whatever pediatrician you're dealing with. Most of them don't have, that's not their training, mental health, but they might have access and networking information for you. And if you have more involved stuff, get a good therapist. I would ask them for educational stuff. Another thing that I look to do, or I tell parents, is like, let's talk about whatever you've already found, because most people are going to find stuff on the internet. And I think that's fine, but you have to help some families like recognize, well, are you reading a blog or are you reading something off of a website? Is this someone's opinion? Is it an editorial, or is it valid medical information off of a valid website? If you're looking for medical stuff like John Hopkins or the Mayo Clinic or New York State, Office of Mental Health might have some stuff. So that's my first thought on that. It really depends on what you're looking for. And that's how I would go about it. I don't know if Jen has something to add or if anyone.
And I'm sorry, I was writing in the chat to someone else, so I missed part of the question. Is the question just what would you do if you had substances, or could we repeat the question?
Yeah, maybe Helen can repeat the question.
I can send it to like the whole group. I didn't realize I was sending it to like in a direct message, so I'm sorry about that.
That's okay.
Oh, that's okay.
Oh,
I'm very bad at multitasking when I'm sick. I'm like, I'm responding to this, and then I'm like, here I am. So sorry.
There's actually no direct, like no way that to the entire group, but I'll send it to Jennifer, you asked.
Well, Helen can read it again too. Helen, can you just read that?
Sorry.
Yes, I'll read it again. And Jessica, that's not you. It's the way we have it set up where the chat can only go through to hosts and co-hosts. It says, any recommendations for good educational resources for families and parents of children who deal with mental health struggles in addition to a developmental disability who are at risk for substance use disorders? And then I see someone put a good tip in the chat, which I will send to everyone so everyone can see it.
Okay. Yeah, I agree with what Steve had said in terms of the pediatrician always being, good line of defense, first line of defense, the school system. But if you're in Schenectady County, New Choices Prevention Team definitely has great resources and toolkits. OASIS has great resource and toolkits. SAMHSA does as well. Even if you're talking about a child with developmental disability, like I think there's some resources that accommodate for that and support those conversations depending on what the disability is. So we could certainly send those resources to Helen if that's helpful to get out to the larger group.
Yes, definitely. I can include that with the recording when it becomes available.
Perfect.
Let's see. What else we got? Any other questions people have not gotten to ask yet?
I have a question. So I am a caseworker. I'm home-based and home and school-based, actually. Preventative work. I was wondering, so I have a family that's kind of putting off getting their child involved with OPWDD. The kid's getting a little older, and I'm just wondering why it hasn't happened yet. I'm feeling they're just really telling me they want to, but why hasn't it happened? So they maybe don't really want to. Can I refer? If they, even though they're telling me they want it, they're gonna do it. Oh, they're totally going forward. It's still my it's been like over a month. Can you refer as a provider?
For OPWDD?
Yes.
That's, I don't know, but part of the reason I don't know is because I don't do that. Like, I wouldn't want that. I would want them to do it, but I understand what you're
Mhm.
saying. You know, you want to kind of hold their hand through it to help it happen, which I think is great. I do know that there are care management agencies in the capital region at least, and it might cover other counties through OPWDD. So they're, you know, they work for OPWDD, but they're their own agencies. And when you refer them, like, they have a care management service that helps families do the referral process for that
Mhm.
system. So what I might do, this isn't what you asked, but what I might do is start with giving them the names of agencies that cover your county and
Mhm.
saying, here, you can just, and even send them, if they use email, send the link like directly to that
Yeah.
information, or the phone number, or both, or maybe sit with them when you can, when you're able to, and do it with them. That's how I would
Mhm.
approach it. What I like about this though is that service, like, I don't think we have that mental health. You know what I mean? So for an OPWDD system, it's a pretty big referral packet or involved. So the idea that they provide care management before this kid's even approved for their services, I think is a great thing.
Yeah, that's my next step, is just sitting with them and doing it, because, you know, I'm done waiting. It's the kind of last piece of the puzzle for me to make sure that this kid is safe and getting what he needs. So I
Yeah.
can't really discharge him without it, I feel. So I'm gonna have to sit down and we'll get somewhere.
If you need more info, just send me an email and I'll see if the couple that I'm thinking of, or I don't know what county you're in, but if they cover it, and, you know, I'll help you find an agency that covers your county if you haven't already. So
Thank
feel
you.
free to reach out. Thank you. I see that it looks like 3 minutes left. So I told Jen yesterday, we're pretty good about stopping right at noon. Anyone else have any questions that they want to ask now?
I don't see any questions. I put the evaluation in the chat one more time. I'm also going to stop the recording to give our captioner time to catch up. 1 second.
And Helen,
I-
oh, go ahead.
Oh, I just wanted to take a quick second before we shut everything down to thank everybody who's on this Zoom doing the work, you know, because I was just listening to Robin's situation, and I know everybody encounters these challenging situations all the time, and where it's like, what are the resources? How do I help this family? I'm in a more macro role nowadays, so I don't do that kind of work anymore. So I just wanted to say I appreciate you all. I know it's hard work and sometimes we don't have the resources we need, and thank you. That's all. I appreciate you.